Dr. Jeff talks love, Dr. Jeff talks life, answers your questions, cuts through the strife. Sex and intimacy, real and true, evidence-based, made just for you.
Hello, welcome to Dr. Jeff Talks About Sex and Intimacy, where we explore the science, the psychology, and the lived experience of sexual health and intimate relationships. I'm Dr. Jeff Albaugh, and today we're exploring a topic that often hides in plain sight in relationships. So it's something really important to talk about, and that's prostate cancer treatment and sexual dysfunction afterwards. You're joining us for episode 63, which is Sex After Partial Gland Cryoablation, What Really Happens? So whether you're joining us live or listening to the recording later, every moment of your amazing life counts and matters. And I count it such a blessing that you take time out of that busy life to join us, to improve your life with all of this great information. I sincerely thank you. You are the reason that this podcast exists. So thank you so much for being here. And if you're watching live, happy St. Patty's Day. St. Patty's Day was today. Had my corned beef and cabbage for dinner. My wife cooked a wonderful meal. So, but you may be watching later, but today is St. Patty's Day. We're connected across so many platforms. We're on Facebook. We're on YouTube. We're on X. We're on LinkedIn. If you're joining us on X, you may need to hop over to one of the other platforms to ask your question and interact with us. If you are on Facebook, a quick favor, please, if you would just follow us. The more people that follow us, the more we can do on Facebook. We really appreciate you following us. And thank you to wherever you're watching from. Thanks for joining. You should visit the website. The website has all of the amazing episodes with all those guests from 62 other podcasts and 62 other episodes with great people. You can pull up any of those and watch them from the website. You can pull up the calendar and see all the awesome things that are coming up with our guests every Tuesday, 7 o'clock Central Standard Time. All that can be done from the website. So go to the website. You can also take us with you. We are where you are. Take Dr. Jeff Talks About Sex and Intimacy on the road with you. We'll go in the car with you. We'll work out with you. You can stream us on your favorite streaming service, Spotify, Amazon Music, iHeartRadio, and more. As always, I'd like to take a moment just to welcome you and say that whatever your sexual orientation, whatever your gender identity, whatever your relationship style, you are so welcome here in this space to learn, and we are so glad you joined us. So welcome. The mission of the podcast is really simple. If you haven't been here before, it is to empower and enlighten you with the scientific information that will help you to improve your sexual health and to deepen your relationships so you can live your one miraculous, wholehearted life with more love. So this episode, a diagnosis of prostate cancer can bring a wave of difficult decisions. For many men, one of the biggest concerns isn't just treating the cancer. It's what life's going to be what it's going to look like afterwards, particularly when it comes to sexual function, erections, and intimacy with their partner. In recent years, newer treatments, approaches like partial gland cryoablation, sometimes these are called focal therapies, they have offered a promising middle path between active surveillance and more aggressive treatments like radical prostatectomy. But what really happens to sexual function after this procedure with partial gland cryoablation? And how should couples think about intimacy during recovery and healing? Well, today we're talking with an expert in men's sexual health and urologic surgery, Hossein Sadeghi-Nejad. Dr. Sadeghi-Nejad has dedicated his career to helping men navigate the intersection of prostate cancer treatment and sexual health. In this episode, we'll unpack the science behind partial gland cryoablation, what the research tells us about outcomes, and what men and their partners should realistically expect when it comes to erections, orgasm, and intimacy after treatment. I know that the men that I serve in my prostate cancer support group on the third Thursday of every month for Zero Prostate Cancer in Gilda's Club are always asking questions about these things. So I'm so excited to have this topic for this episode. If you or someone you love is facing these decisions about prostate cancer treatment, this conversation is going to offer clarity, hope, and practical insight. So my guest today is Hossein Sadeghi-Nejad. He is a nationally recognized urologist specializing in men's sexual health, prostate cancer survivorship, and reconstructive urology. Dr. Sadeghi-Nejad serves as professor of urology and director of men's health at Rutgers Robert Wood Johnson Medical School in New Brunswick. He is a fellowship-trained expert in male sexual dysfunction, and he has extensive experience treating erectile dysfunction, Peyronie's disease, and sexual complications following prostate cancer treatment. And throughout his career, Dr. Sadeghi-Nejad has been a leader in advancing treatments that not only address cancer control, but also preserve that important quality of life, especially sexual function and intimate well-being. He's authored numerous peer-reviewed publications, and he is a sought-after speaker. He has a radio show as well that I've been on. He is a colleague and friend, and he has a wealth of information about men's health and sexual medicine. What makes his work particularly valuable is his commitment to helping men and their partners really understand the real-world outcomes of treatment and to find pathways back to satisfying sex and intimacy. So without further ado, I am so excited to welcome my friend and colleague, Dr. Sadeghi-Nejad. Welcome.
So I wanted to thank you, Jeff, for that very kind introduction. One other minor glitch. That was a very generous and kind introduction. And I maybe did not send you the updated bio because I am very proud of my Rutgers heritage, but I've been at NYU since 2023. So I am honored to be part of this show, and I'm a professor of surgery, as you said, and director of men's health at NYU Langone now. This is since 2023. And part of what I'm going to talk about is actually the great work that we do at NYU focused on focal therapy for prostate cancer. These are my disclosures, and I wanted to acknowledge our chairman, Dr. Herb Lepore, as well as my colleague, Jim Wysock, who do a lot of this work, and I'm able to collaborate with them on managing prostate cancer and focal therapy. Was a chair at Johns Hopkins back in 2008. The discovery that would have the greatest impact on prostate cancer would be the development of accurate imaging of tumor within the prostate. Well, guess what? We are there now because we can see that multiparametric MRI has really been at the forefront of the diagnostic evolution. If you look at the PROMISE study, this was a landmark level 1B evidence study showing that multiparametric MRI improved how well we can pick up cancer, the sensitivity of 93% compared to the days when we were doing transrectal ultrasound biopsy of the prostate. And it also has been shown through the precision study that we now have better detection of clinically significant cancers. You can see that when we use imaging and targeted biopsies, we have a 38% detection as compared to 26% when you're just doing systematic sampling. Now, you can see the limitations of our field in terms of doing biopsies. If you look at active monitoring versus prostatectomy or radiotherapy done in the PROTECT trial, this was a study that randomized a large number of men, in this case 1,643 men, to getting active monitoring or prostatectomy or radiotherapy. And interestingly, the survival was very similar between these cohorts, right? Active monitoring versus prostatectomy versus radiation therapy, all north of 95%. But the metastatic progression was very different, like 6% in the active monitoring group versus 2.6% in the treated groups. So it is very important to try to pick out who is going to advance and try to give a treatment appropriate to that group. Now, partial gland ablation is a relative newcomer to our field and what we offer prostate cancer patients. There's a growing list of energy sources, from thermal ablation, including HIFU, that's high intensity focused ultrasound, transrectal therapies, and of course, cryoablation, which I'm going to focus on tonight, as well as some non-thermal therapies. Now, the paradigm has shifted so that we were only focused on extirpative surgery until relatively recently. This is entailing comprehensive removal of the prostate. You want to have a margin of healthy tissue around the removed cancer, and this traditional extirpative surgery, of course, followed anatomic landmarks. Moving on to what is offered to many of our patients today, you have ablative surgery, which is image guided. You are custom treating the area that is affected by cancer and is tailored to the tumor and the margin, and is, as I said, guided by imaging. Outcomes have been wonderful in terms of the news that we can give our patients. 400 plus men have been treated to date. These are groups with intermediate risk prostate cancer, and I'm talking about the cohort at our center at NYU Langone. 90% of these patients did not require whole prostate therapy, and 97% of those treated did not have cancer in the zone that was treated on biopsy. Most importantly, focused on this talk for Jeff's show tonight, there was no incontinence, and 96% of the patients returned to baseline sexual function. Now, one of the things that's very important to stress here is that in this arena, in those who are getting partial gland treatment, cryoablation, those with good baseline function had much better return of function, as opposed to those who did not have excellent function to start with. And at 5 years, 90% of those did not require a whole gland treatment, right? In other words, we could limit the treatment to just the area affected by cancer. Now, here's another important message here. If you look at what's defined as the threshold for potency, when you look at part of the validated questionnaire, this is question number 2 on the sexual health inventory for males. When you had erection with sexual stimulation, how often were your erections hard enough for penetration, right? Questions or answers 3, 4, and 5, sometimes, most times, and almost always, this was defined as a threshold for potency. And if no baseline erectile dysfunction existed in our cohort, there was a 96% restoration of potency at 2 years. So this is a very, very important message to drive home, that for a certain group of men who have localized prostate cancer, you can offer focal therapies with excellent maintenance of baseline erection and restoration of potency of 96% at 2 years. So the key point here is that we want to stratify outcomes according to baseline prostate symptom score, as well as sexual health inventory for males, which is imperative to assess the true impact of this treatment, partial gland cryoablation, on functional outcomes. So we did a study here at NYU looking at assessing the impact of PGCA, primary partial gland cryoablation, on sexual health inventory for men, looking at various determinants and aspects of sexual function. We also looked at penile length and curvature 1 to 3 years after treatment. Outcomes included changes in the SHIM score, that's the validated questionnaire, rates of sexual satisfaction, dissatisfaction, and the prevalence of marked changes in erectile function, orgasmic function, penile length, and penile curvature. All patients had a pre-treatment multiparametric MRI. The treatment, this cryoablation therapy, was offered if there were a Gleason grade group 1 to 3 disease, meaning not sort of the severe group associated with PIRAT score more than 1 in the target, and no contralateral Gleason grade group 1 disease, gross extracapsular extension, or distal apical disease. Again, you're treating those with a very defined area of cancer within the prostate. And then we gave them the sexual function questionnaire at 3, 6, 12, 24, and 42, as well as 60 months during their scheduled postoperative visits. Inclusion in the study was limited to those who completed the questionnaire and had a baseline shim score of more than 17, going back to what I was saying earlier, those who had good or very good sexual function. Sexual function dissatisfaction and satisfaction was defined based on the response to the following questions. If you were to spend the rest of your life with your sexual function the way it is, how would you feel about that? Pleased, delighted, mixed, mostly dissatisfied, unhappy, or terrible? I will tell our viewers and listeners that this actually is not validated. This is a questionnaire. This is a question that came from a questionnaire that's been validated for prostate health, IPSS. But we thought it's a very, very good way of gauging a patient's overall satisfaction. And men who responded dissatisfied, unhappy, and terrible were considered to experience sexual function dysfunction based on this question. So again, 300 men in the registry since 2017 is a little bit higher now. 100 completed the questionnaire at 1 to 3 years after treatment. And you can see again what I was emphasizing before, that even though in the total cohort, you could see that the mean shim score was starting at 22.4, that's a decent score, and dropping to 15.4. That is a pretty significant drop. But then to go back, if you look at the bottom two columns, you see that there is a very big difference between those who had better shim scores, that's the second row, as opposed to those who had a lower function. Now, there were 75% satisfaction versus 25% dissatisfied with their treatment. The men had shim decrease of 5.1 versus that's supposed to be mean shim decrease of 5.1 or 12.2 respectively, meaning that if your erection hardness and erectile function decreased significantly, obviously you were dissatisfied with the treatment. And we found that marked erection worsening, as opposed to other aspects of sexual function, was really the only predictor of whether these men were satisfied or not satisfied with their sexual function. 12% of men responded that their pleasure from orgasm were markedly worse after this, and 2.2% reported marked decrease in penile length. 0% reported penile curvature following partial gland cryoablation. And again, to put it in perspective for our viewers and listeners, these numbers may not mean that much to you if you haven't been treated for prostate cancer, but I will tell you that they are dramatically better than those patients who undergo, let's say, radiation therapy or undergo radical prostatectomy. This is not to say that those treatments should not be offered. Again, the partial gland cryoablation is for a select group of patients with confined disease. The point is, not everyone needs to get the more radical treatments. And if you get this treatment, well, sexual function and incontinence is better. With 5-year follow-up, 90% of the men with intermediate risk disease have not undergone salvage, radical prostatectomy, or radiation, meaning that when you select the patient correctly, the treatment you're offering them is enough. They don't need to get additional treatments. And what about decision regret? The overall decision regret was 20%, meaning of those who got cryoablation, how many of them said, I wish I got something else? 20%. And this exceeds the numbers that you get for breast and thyroid cancer. We surveyed the patients treated at NYU Langone with cryoablation. The treatment-related regret at our center was actually 14%, which is really outstanding. So the majority of men undergoing this treatment, partial gland cryoablation, with good baseline erectile function, are satisfied with their sexual outcomes. Marked adverse changes in penile length or curvature are rare. And 25% of men experience sexual function dysfunction following the treatment. Pre-treatment counseling regarding potential sexual dysfunction is very important. The limitations, of course, is lack of a comparative treatment and potential reporting bias in our series. And on that note, Jeff, I will stop and open the floor for any questions you may have.
Wow, great information. And this is so exciting because you and I both know we work in a world where These patients who've had their prostate cancer treatment, the number one long-term side effect complaint is sexual dysfunction. And I
Exactly.
think to put that into perspective, we've talked before a little bit about this, but when you look at some of the previous studies with radical prostatectomy, for example, about 80% of men are struggling with erections 2 years later. That's
Correct.
80%. And when you think in your study, it's like you had like 96% of the patients said they recovered and their erectile function was, they were able to have.
Especially if they started with a good number. See, that's the key point. And men, and I always tell this because at NYU Langone, I'm privileged that this is a main center for offering the treatment to our patients. And the vast majority of them see me even before treatment. Of course, I see also our patients who are getting the radical prostatectomy and many of those who get radiation, but I pretty much see all of the ones who are getting this focal therapy. And I tell them that when you're starting with a good number, the chances are you will maintain it. And I think that is very important for them to know.
I think you're absolutely right. And we tell patients too, if you're starting with problems, that gives you a disadvantage, and those problems are going to probably be worse after these treatments. But still, even for those guys, because often those are the men that feel so broadsided by it because they started with good erections.
Right.
Most of the time when you have prostate cancer, you have no symptoms. So they're like, nothing was wrong. It was found from screening or whatever reason that it was found. And now I have erectile dysfunction afterwards. So those are the men who are profoundly affected. Any of the men can be affected, right?
Exactly. And you know, one of the things, Jeff, that has been very eye-opening for me is before coming to NYU, I was not directly exposed to this treatment, to men getting partial gland cryoablation. And I was in New Jersey, many outstanding surgeons doing radical prostatectomies robotically, patients getting high quality radiation from some of our colleagues at Rutgers and Hackensack. But coming to NYU, when this treatment is offered, I have to tell you, I was very surprised that I would see the patients pre-op, I would see them post-op, even at their first post-op visit with me, which would be a month later after the catheter would come out.
Wow.
I cannot tell you that there are many patients that I would see, how surprised I was that many patients that I see who were perfectly fine, like their erections were as if nothing had happened. And yes, with radical prostatectomy, I do see great outcomes, but it would often take longer, right? Because the process is different, the nerves can be affected, the blood supply can be affected. Here it's much more limited, and I'm not saying this happens to everyone, but that 96% number is very real. And I do see some of these guys having minimal effects, which is really, really encouraging.
That's so exciting. And, you know, I think listeners, to help you understand, just like women who have a mastectomy and have the breast removed versus a lumpectomy, this is kind of the way you can start thinking about what we're talking about in terms of this prostatectomy, removing the entire gland and the seminal vesicles and everything, a radical prostatectomy, versus this partial gland cryoablation where they treat the area. Now, not everybody's a candidate, of course, for that, as you said earlier, because certainly if your prostate cancer is found on each side or throughout the prostate, you're not going to be able to do a partial gland cryoablation. But for the right patient, this is amazing and exciting for those patients to have an option like this that could preserve sexual function and their quality of life.
Absolutely. It really is wonderful. And remember one of those earlier slides when I showed you, yes, you know, you look at 15-year survivals for radical prostatectomy or radiation and watchful waiting. For many of the men, the numbers are similar. But then there is that slight difference, right? That the metastatic rate is slightly different. So you really want to pick out those men who will progress. And then the later slide showing that when the patients are picked appropriately, such a high percentage of them do not need to be retreated. It's not like you're treating them with focal therapy and half of them are going to be treated with radical prostatectomy or radiation down the line. That number is very high. It's north of 90%, right? So that's very, very important. Wow,
it's really exciting news. I mean, I have to say, your study is really compelling and really exciting. And I'm hearing and seeing similar results with focal therapies that are occurring, because I run a prostate cancer group, and
Of
we have
course.
quite a few people who are doing focal therapies here at University of Chicago and North Shore and Northwestern, different places. And I'm hearing really exciting news from them about preservation of erectile function as well. So it's exciting. It's great to hear it from your institution and to know we're seeing it from other places too. So this is great news for men who qualify for these types of treatments in terms of prostate cancer treatment.
And again, just to emphasize, the public health message is not that you should forego radical prostatectomy, you should not get radiation. No, there's a right treatment for every patient, depending on the sort of the severity of the disease, the extent of the disease. You just need to be at a center that can offer you the right treatments.
Absolutely. And that's where we highly encourage people, get a couple opinions, make sure you see a couple different people, go to institutions that are doing focal therapies. They know the exact criteria, because, and this is what I think is really exciting about all this, is this again is promoting individualized patient-centered care. It really has to do with no one else's, your particular Gleason score, your particular PSA, your particular parameters of prostate cancer that guide your treatment. And that's really important, because sometimes, thank God we have radical prostatectomy, because we know it's saved many lives over many years. But the exciting thing is now we have other things depending on your particular situation, and that guides it all.
Exactly.
So it's really exciting. Well, I have a couple questions for you. The first one is,
sure.
From your experience, the listener says, what are the biggest misconceptions men and couples have about sex after focal therapy? And what do you wish every patient understood before choosing this treatment?
Well, I think the misconception is there until they speak to an expert who has experience treating these patients with this modality, and hopefully they will put their misconceptions to rest and educate them. I think the misconception is that all prostate cancer treatments, in terms of the adverse effects on continence and sexual function, are created equal. We know, for example, you and I know that if you even compare radical prostatectomy to radiation therapy, there are big differences, right? With radical prostatectomy, the numbers initially may not be as good, even with a robotic technique, because those nerves can be stretched or can be affected by the surgery initially, and then with time, a lot of that can recover, right? We can see improvements 12 months later even. And by the way, in parenthesis, before I answer your question fully, that's one of the things also that I've seen with focal therapy. Sometimes you could see recovery. Those patients who don't recover right away, you can have recovery going on beyond 1 year, even close to 1.5, 2 years. You could have continued improvement. We're also treating a lot of the patients with penile rehabilitation, putting them on medications right at the beginning of treatment, or even just before, and having them continue the pills like low-dose Cialis to sort of keep the system well oxygenated and vasodilated, if you would. But to go back to your question, I think in terms of the misconception, it's that not all treatments are created equal, and I try to educate the patients about that. And again, the focus is to make sure the right person, the person gets the right treatment for them, and then we work on getting their sexual function where it needs to be. The other misconception, which is very common and sometimes, unfortunately, doesn't get explained to the patients appropriately, is the issue of orgasms versus ejaculation. And after all of the radiation therapy and radical prostatectomy, many men will have the ability to have orgasm, but after those treatments, the ability to ejaculate is pretty much zero. With this, you can have ejaculation. Not everyone, but a large number of patients. And I think that's another big difference and misconception.
And I think that's a really important point because we don't always talk about orgasm and climax, and men do feel an effect from that, from these prostate cancer treatments with the radical prostatectomy, the radiation, different things. And it's good to know that those reports are better with that as well. Because some men, when you look at the studies, you see some men say it's similar to what it was before their radical prostatectomy or their surgery. Mm-hmm. Some say that it's diminished, certainly, or different, and are upset about that. A very small percent actually have more intense climax afterwards. That's a really small percent, but most people either say it's diminished or different, or it's similar. But you think men are affected in terms of orgasm, and we don't always talk about that, but it's another thing that is important to some of these men. I hear them talking about it in my group quite often, that was affected as well. So that's kind of exciting, because with your prostate gone, you're not going to ejaculate. There's one small gland left, so maybe a little bit, but basically, like you said, it's not going to happen. You're going to get the sensation, but you're not going to have fluid come out. So with this, sometimes they can still have the ejaculate fluid come out with the sensation.
Right. And then, of course, it's a whole new topic, whole new discussion. But another very interesting sort of angle that comes into all of this, Jeff, is the whole concept of testosterone. That when I was in training, in the late 90s, nobody would ever even think of giving testosterone to prostate cancer survivors. Whereas now we know that if you have been cured of your prostate cancer and you have low testosterone level, and as a result you have low libido, low energy, you can be treated. The magic word there is follow-up. You need to monitor these patients and follow them up, but in fact you can give testosterone to patients, which I think is a very important concept.
Yeah. And also going back to your earlier point, you had said very clearly that how you go in terms of really good erectile function is important. And that's what I think is so great about centers like yours, and where I worked as well and work now, where we see patients before surgery. We make sure their erections are in their best form. We maybe start, like you said, the phosphodiesterase type 5 inhibitors like sildenafil and tadalafil and things like that, and make sure they're in their best shape. And then we continue that after their treatment to help them along. That's some of the penile rehab strategies that we do to preserve function too. So that's a really important thing to talk to your providers about as well, listeners, is making sure that you are being proactive about your sexual function before you go into treatment and after you go into treatment, to work on that, because that can make a difference too.
Exactly. And lastly, Jeff, I wanted to tell all your listeners that, this is not to pat ourselves on the back, but in year 2026 at dedicated centers, it would be the exception, I would say rare exception, that erectile dysfunction, sexual dysfunction cannot be treated one way or another. So for those listeners and those viewers who may not be where they need to be, I would just say, don't get discouraged. Just find the right specialist. We'll work with you and get you to a point where you can resume intimacy and be where you need to be.
Definitely. I have one more question for you that came through that I thought was a good one as well. It says, my partner says they just want closeness, but I still feel pressure to perform. How can couples redefine intimacy during recovery so it doesn't feel like everything depends on that erection?
It's such an important point, and couples, individuals see things differently. I very strongly encourage our patients to see therapists. As a surgeon, as a urologist, I don't necessarily have the tools to work on exactly the question that your guest is asking. Sort of some of the mental health aspects of this, the pressures, the societal pressures, the family pressures, the spousal pressure. Again, everybody's different, so I encourage you to see someone who can help address these questions. And yes, it's not all about the erection. And I have many, as you do too, I'm sure, we have many couples, young and old, who do not need to have intercourse like physical intercourse to be happy. But of course, our goal is to make sure the person is whole so that they can, if they want to, but it's by no means implied that you must have an erection to be happy and be intimate. But I encourage our listeners to talk to each other, to see therapists if they need to. There are wonderful resources out there, sex therapists who can offer a variety of solutions to our patients.
Absolutely. And as a certified sexuality counselor, we always address these things in my clinics. And so it's so important. And usually, like you work with therapists and nurses and people who can help with all this stuff. I think a big part of it is exactly what you said, listener. So sort of redefining from what society says, well, it always leads to intercourse, or it's always about penetration. And I think that can be really important. And we work a lot with our couples who are going through prostate cancer treatment on what are their goals? What do they want? And a lot of times they want to feel connection and pleasure, and you don't have to have an erection to do that. There's 2 previous excellent podcasts on non-penetrative sex. We also call that outer course. We had a panel discussion on that in the past, and we've had several episodes on that. So if you look back, you'll find some really good information on that. Really important topic that sometimes people don't always know the answers. We did the panel discussion because I had a patient myself who said, we just don't know that much about it. He said, my wife doesn't even know her own anatomy. So we went over all that. And so I think there's some really good resources out there, including some previous podcasts, and absolutely those therapists and counselors who can help you.
Can do wonders.
Absolutely. Because we both know we have patients who have wonderful, fulfilling, intimate sex lives after prostate cancer treatment. Absolutely. It is. I've even had people in my studies too who said, I think it's gotten deeper and more fulfilling now because now we really pay attention and work on it more. So
right.
it can be a good thing. It's still, if you're feeling upset, maybe even defeated by some of the struggles with sexual dysfunction after prostate cancer treatment, you're not alone. But we're here to offer you hope. And like right. You said, there are treatments. We can help you from all sides. And so seek that help. And I think it will be really good. Wow, I really am so excited about your results from NYU. And I thank you for sharing those with us. My group is always asking about focal therapies, and I'm really excited about this partial gland cryoablation. Any final message you'd like to give our listeners? And then I'd like to let you go because I know it's late in the evening on the East Coast.
I just want to thank you for having this show, for being so informative for your patients and your listeners. This is the first time that I'm participating. It was wonderful having you on our show. I do a men's health show every first Wednesday of the month, as you know, on Dr. Radio, also focused on the same topic. And I hope that these collective efforts would, at least in some little way, help a person out there who may want the resource, who may want to hear that there are solutions for their problems. So I just wanted to thank you for doing this, and you're such a wonderful host, and hopefully I'll be back sometime.
Definitely. I can't thank you enough for taking time to share your expertise. We have had a history together with Sexual Medicine Society of working on projects. It has always been a pleasure and an honor to work with you on all the different projects we've worked on. And I think we both share an incredible passion for informing and enlightening people with the information they need to have better sex lives. So thank you.
That's right. You're good. Jeff, you're the best. Have a good evening, everyone.
You too. I'm going to go to my centering exercise, listeners, as we do. So we have the rest of the program we will go through with you. And so as we do at this point, I would like to go to that part. So, all right. Before we end today's episode, I'd like to invite you to take a brief moment, as we do at this point, to reconnect with your body and with a sense of possibility. If you're able, sit comfortably and allow your shoulders to soften and relax. Take a slow, deep breath in your nose and gently exhale through your mouth. Take another slow, deep breath in and let it go. Now, as you continue to breathe, Bring your awareness to your body, not as something that needs to perform, but as something that carries you through life. Many men facing prostate cancer treatment feel pressure to get back to normal quickly, especially when it comes to erections or sexual performance. But healing is often a journey, not a switch that flips overnight. As you breathe, consider this thought. Intimacy is not defined by perfection or performance. It grows through presence, connection, and compassion for yourself and your partner. Take one more slow breath. Exhale gently. If you're navigating prostate cancer or changes in sexual health, remember you are not alone. With the right information, support, and patience, many, many men and couples rediscover meaningful and fulfilling intimacy. I promise it's possible. Thank you so much. Let's go to what is coming up next week. I'm really excited about next week's episode. What's up next week on Dr. Jeff Talks About Sex and Intimacy?
Military service can profoundly shape how veterans experience their bodies, relationships, and sexuality long after active duty ends. In this episode, Dr. Jeff is joined by Aja Brodsky, who will provide information on how service-related experience influence sexual identity, intimacy, desire, and connection. From the impact of trauma and stress to changes in roles, bodies, and relationships, this conversation offers a compassionate, veteran-centered look at sexuality after service and pathways toward healing, reconnection, and pleasure. Join us on March 24th at 7 p.m. Central Time to learn more.
I am so looking forward to that episode with my friend and colleague, Aja Brodsky. She is a certified sex therapist, and we work together at the VA. So she serves our nation's veterans as well, and I thought that was an important topic for us to discuss here. Listeners, I just want to take this final moment to thank you. I know it's a lot of information. I'm excited about the emerging research, the exciting research about focal therapies, that focal therapies are now available for the right person who needs that type of therapy and doesn't have to have their full prostate necessarily treated because they have prostate cancer in a very specific area where it can be treated focally. That's exciting. And then how it preserves quality of life and sexual function. But if you had a prostatectomy, know that there are treatments, there is help, there is hope. This is what the podcast is all about, is really giving you the information you need. There are so many great episodes on the different treatments, one specifically on vacuum device, one specifically on injections. We have one coming up where we'll talk about Eroxin, a newer topical therapy. We've had several on the penile implant surgeries and with several different surgeons. So there's great information and there are treatments. I know it can feel daunting, but hopefully go to the website and find the information you need. My hope and prayer for you, whoever you are out there, is that you get and find exactly what you need to have a beautiful, miraculous life, again, that you really are hoping for. So thank you for joining us and have a good one.
Dr. Jeff talks about sex